Good morning, everyone. Thank you for joining us today. My name is Joan Betorf. I'm a professor in the School of Nursing here at the University of British Columbia's Okanagan campus in Kelowna, and I'm director of the Institute for Healthy Living and Chronic Disease Prevention here at UBC. Before we begin, I want to respectfully acknowledge that UBC Okanagan is situated on the traditional, ancestral, and unceded territory of the Silk Okanagan Nation and their people. And I'd also like to acknowledge that many of you might be joining us from other places, both near and far. And I'd like to take this time to acknowledge the traditional owners and caretakers of those lands as well. We're really delighted to be able to bring this webinar to you today. It's co-hosted by the Institute for Healthy Living and Chronic Disease Prevention and the North Okanagan Hospice Society. We've had the pleasure of working with the Northern Okanagan Hospice Society over many years to bring webinars like this to our community and really the community across Canada. Before we begin, I want to let you know that there is some closed captioning that's been enabled that you can move to your preferred place by clicking and dragging it to where you'd like, and you can close it off. Also, we invite you to use the questions, the comments, put your questions or comments in the chat at any time during the session. Please do that, and we welcome and we'll provide an opportunity for Dr. Kaasalainen to respond to those questions and comments towards the end. But please do feel free to jot comments or questions in at any time, and even just to let us know your interest in this topic. So before we begin then, I'd like to introduce Clara Dick, who is the Education and Resource Leader at the North Okanagan Hospice Society, who will introduce our speaker. Clara.
Thanks, Joan. So North Okanagan Hospice Society is so pleased to have this ongoing partnership with the Institute for Healthy Living and Chronic Disease Prevention. And like you said, it's been for many years and it's been very good. And we're so happy to bring this webinar to those near and far. So on behalf of the North Okanagan Hospice Society, I would like to introduce Dr. Sharon Kaasalainen. She is professor and Gladys Sharpe Chair in Nursing at McMaster University. She will be sharing on improving capacity in long-term care to implement a palliative approach to care, pearls for practice. So Sharon, I'll turn it over to you. I'm looking forward to what you have to say.
Great. Thanks, Clara, for that lovely introduction. Was super excited to be invited to speak to you all today. I don't get many opportunities to speak to people in BC, so it was especially nice to get the invitation, and it would even be better if I could be there in person and meet some of you face to face. But nonetheless, we have this opportunity. And it's lovely to be able to put lipstick on and get dressed up and have good reason to do that. So, very, very excited and really interested in hearing some of your comments and questions as well, because I know some of my colleagues who work in this area in BC are doing some wonderful things. So would love to hear some of your stories and would welcome those comments at the end. So today, briefly, what I wanted to share with you today is really provide some rationale for why a palliative approach to care is needed in long-term care homes. It's been recognized across many countries as an important change that's needed in our system, and particularly in long-term care homes. I thought I'd share with you some work that I've done with colleagues across the country and looking at a scoping review where we looked at different models of care that have evolved over the past really 20 years around implementing palliative care, or more recently a palliative approach to care in long-term care. And then based on some of this work, we've developed a program that has been developing over the years and still developing, and we have called SPA-LTC, so Strengthening a Palliative Approach in Long-Term Care. I'll also talk about some evaluation work that we've done through various research projects and share some tools and resources that we've developed along the way with families and residents and staff to help support the implementation of the program. And then finally, I'll just close with some final thoughts and some next steps that we're envisioning within our research team and within our partnerships. So it's not surprising that we need a palliative approach in long-term care. I think most people who come to these kinds of sessions, that's why they come, and they, you know, I don't need to convince you of the need. But traditionally, we've seen shorter and shorter lengths of stay in long-term care over the past 20, 30 years. And the average across the country is less than 18 months, where people come to long-term care and die within 18 months. And in BC, I'm seeing stats that are much shorter than that, even under 12 months. So there's definitely a need for looking at planning for end of life and supporting families and residents in their journey in long-term care towards end of life. We're seeing, you know, frailer and frailer, more complex residents coming into long-term care. The old days, you know, 30 years ago, and even when I was working in long-term care about 20 years ago, residents sometimes would drive themselves to long-term care and park their car in the parking lot. And many of them, you know, lived for 10, 15, even 20 years in long-term care. Now we're seeing them in the community longer, which is good. But coming to long-term care, by the time they do come, they're very frail and needing pretty complex care. Dementia is one of the primary reasons, I think, why we see people come to long-term care when the family caregivers at home can't provide safe care anymore. So estimates around 75 to 80% of residents have dementia, and it's fairly progressed at that point, which leads to more complications in care and challenges with having conversations about values and wishes and decision making for end of life. And because of that, we're seeing, you know, decisions being made with families very last minute. They're not prepared, they're not informed, and what we call in crisis mode. So really struggling, you know, to make some of these difficult decisions, and we're seeing negative effects carry with them into bereavement. So there's lots of things we can be doing so that we can avoid that crisis mode at the end of life for families and residents. So a few years ago, actually 2 years ago, I was asked to do an editorial for palliative medicine based on some of the work that we've been doing, as well as work others have been doing internationally. And but what some common themes really that we've been seeing and issues that are really preventing, you know, presenting as barriers to implementing a palliative approach. First and foremost, the need for education and training for long-term care staff. So, you know, we're seeing 80% of the workforce as PSWs, care aides, are frontline staff, and their education has varied over the years, and there's not a lot of palliative content. I think that's changing now. I'm seeing lots of positive things coming, but we're still seeing the need for strong training and skill building for all disciplines in long-term care, and we're hearing that from them as well. Given the complex care that we're seeing in long-term care, there's definitely a need for more education and training. So some of the other things that we've been doing within our program, given the lack of resources in long-term care and the capacity, is building so internal capacity. So that could be through palliative champion teams and providing some skill building and training with the champion teams, but also leveraging resources outside of the long-term care home. So what we call external facilitation, whether it be community palliative consultants, nurse practitioners who provide outreach to long-term care homes, and palliative specialists who often can support long-term care homes as well. So, and volunteers. So whatever we can garner outside of the long-term care home to help support them is very important. And the final piece, particularly from a research standpoint, is are we looking at the right outcomes when we're looking at effectiveness and evaluating different interventions around a palliative approach in long-term care. Traditionally, we've looked at ER admissions, and that's certainly what our group has focused on. That's what the funders like to see, decrease costs, but are they family-centered? So should we be looking at other outcomes that are more family-centered, resident-centered? Not a lot has been published, and not a lot of quality tools exist out there. So certainly a need to think of some of those outcomes that we should be measuring and ways to measure them. So from our scoping review we published in the Canadian Journal of Nursing Leadership, and these have been reported in other reviews as well, but primarily there's been 4 types of palliative models or programs in long-term care. The first ones that we started seeing, 15 to 20 years ago, because there wasn't a lot of capacity in long-term care homes to provide palliative care, or really end-of-life care is what it was called then, we would draw in experts from outside of the long-term care sector, often, palliative physicians who would come in, at end of life, usually the last couple of weeks of life, and either treat pain or do what they have to within the last couple of weeks of care. That's, was helpful at the time, but generally we don't have a lot of palliative specialists, and they're getting swamped with their own practice and community practice. So we couldn't, what we're seeing in those models is it was only a handful of residents that could get access to palliative specialists. So then, the focus was on developing in-house capacity for end-of-life care. So again, under 6 months or even the last month of life. So trying to build staff capacity and looking at more of a generalist model within long-term care, where everybody would have abilities and skills to be able to provide end-of-life care. Then we started moving more towards realizing we need to look beyond end-of-life and look at earlier on in the trajectory and preparing families earlier and having important conversations earlier. So this is when a palliative approach we started focusing on about, I would say, 10 years ago, and there was the Way Forward document from the Canadian Hospice Palliative Care Association that started looking at palliative care differently. So you're looking at not just when people are imminently dying, but looking at people when they come into long-term care ideally, or even before they come to long-term care, but getting people more comfortable with talking about palliative care and their values and wishes. And finally, there is the fourth model that resonated well with myself and my team, ways that we could bring in external support to implement a palliative approach, as well as building in-house capacity through training, skill building, and leveraging an internal palliative champion team. So those are traditionally the 4 kinds of models. And the last model was really what helped inform our SPA model, SPA-LTC program. And you can see here, there's many components. We've kind of parceled them into components that are more staff-focused, ones that are resident and family-focused, and then after a resident dies, and for families into bereavement. So the palliative champion team, as I mentioned, is one of the critical pieces that we've seen in our work, getting those champions on site, enthusiastic, because they'll be leading the team, leading the home, and other staff need to look up to them and use them as resources. So the champion team is for sure doing some education and training beyond, hopefully, just the champion team, but to all staff, which is a huge challenge. Comfort care rounds, I'll speak a little bit more about them later, which is a way to leverage these community palliative care consultants, which is what we used in Ontario, to help host these comfort care rounds with staff as a way to provide some on-the-spot training and resident debriefing about resident deaths, which is often neglected as well. So those are key things that we've done with staff. With families and residents, we've developed some informational pamphlets to help provide some information to families and residents earlier on about what they may expect as their condition worsens, some questions they may want to ask healthcare providers that we've heard are common questions. And sometimes families just need permission to ask these questions. So we thought having them in the pamphlet would give them permission to do that. And also having some resources that are local to the different regions or provinces. The Palliative Performance Scale, that's something that was developed out in your neck of the woods, Victoria Hospice. I'm sure you're all familiar with it. It's a nice simple tool, and we found has worked really well in long-term care. So there is a lot of critique around using it in long-term care because it wasn't developed for long-term care. It was developed more for oncology population in the community. But we have found it works fairly well, and it gives a nice way for care aides or personal support workers to communicate resident decline to nurses, which often has been challenging for them to be heard about those their observations in their clinical work. And finally, for families, this is another big piece to our program that we feel really has made a huge impact on some of our outcomes, is holding a palliative care conference. So this is where families come hopefully on site in person to a meeting with the physician, with the nurses, hopefully with the PSWs or care aides and other staff to be able to talk about questions they may have, concerns they may have, and then make some important decisions about end of life based on preferences and values of the resident. So if the resident, and often that's the case in long-term care, isn't able to engage or participate in palliative care conferences, if they can, that's great. We would love them to come, but most often, the residents are not able. So those decisions are made, have to be made with the family. So lots of supports needed for families, information, and this opportunity gives them a chance to have discussions with the healthcare team so they feel better about their decisions in the end. So that's our palliative program. We've also developed a model of kind of key outcomes or key areas that we feel our program aims to achieve. So I've talked a lot about preparing family members, and we've developed some resources to help prepare them better for end-of-life decisions. Symptom management, we can't get away with that in palliative care. That's very important, and we hear, a pain-free death is really one of the goals for families and residents. So there's some symptom management tools as well. Caring relationships are very much a big part of our program. And how can we build caring relationships among families and staff, families and residents, residents and staff to staff as well. So caring relationships within everyone involved in the circle of care. And again, we have some resources that we've developed to promote caring relationships among everyone. And organizational capacity is huge because we know most long-term care homes don't have a lot of capacity and don't have a lot of extra resources to implement a palliative approach or anything new. So how can we build on what currently exists and leverage expertise outside of the home to build that organizational capacity? So all of our work has been framed around participatory action research. It's a neat way to do research. I certainly enjoy it. It gets me close to the clinical setting. It gets me close to residents and families, and hearing their voices and working with them to design our tools and our resources. Because at the end of the day, we want it to address their needs, not our needs, and we want it meaningful to them. So our research started way back. Some of you may know Mary Lou Kelly. We worked together on the Palliative Alliance back in 2012, maybe even earlier than that. So that was really where we first started using PAR research within a palliative approach. And the cool thing is it's really quality improvement. I mean, you're really getting some data, looking at the data, making some sense of it, and then trying to respond to address needs that we're seeing in the population or in the setting. And often that has resulted in creating different tools. So we have, again, following our program that I talked about earlier, we have tools that are specific for long-term care staff. And some of the things that we knew right off that we would have to work on is some education and training around implementing a palliative approach. So often we realized early on that there's already a lot out there, certainly for registered staff. So we've started to use the LEAP long-term care in our last 2 studies, and that has worked well for our palliative champion teams. But what we found when we went to do our final data collection and our final interviews with all staff, not many of them had access to training and education. It was the champion team, and ideally we were hoping to get to train the trainer model, but the resources are pretty scarce, and it's hard to get all staff off the floor to attend training. So this was one of our studies that we did recently, but what I thought was particularly interesting, every group that we assessed improved knowledge or comfort with end of life, providing end of life care to residents and families. But if you look at the bars, the PSWs and the support staff, were essentially the recreational aides, dietary, any non-registered staff who weren't a healthcare aide or personal support worker were considered as support staff. But they're often ones who are asked by families who have questions about end of life or values or wishes, because those are the ones, that are handing out the meals at the dinner time and the family see. But they had the lowest comfort out of everyone in terms of being comfortable with end-of-life care or talking about end-of-life care or supporting families and residents. And they're the ones who aren't usually included to any kind of education. So here they were included, and they, you can see, increased the most. So their comfort with providing end-of-life care increased the most. So that told us that they are the ones we should be focusing on because they're not often included in education and training, but have the most to gain from doing so. So our comfort care rounds is one opportunity that we can do that. It's open for all long-term care staff, any discipline or role within the home. But essentially, we have an hour with a consultant, or it could be an in-person or an on-site staff as well if they have, education, training, and palliative care and feel comfortable taking that role on. But it's a chance to talk about current residents who may be approaching end of life. There may be some clinical issues that have emerged, or it often starts with talking about residents who have died over the last month, and it gives staff a chance to debrief, talk about what went well, what didn't go well, and that's important. I think staff need a chance to talk, particularly those situations where it wasn't a good death, they're not happy with the care that happened for a particular resident and family, because they've developed these relationships and they, carry this guilt. So it gives them an opportunity to talk about some of those things. And also having a palliative consultant or someone who can answer questions is a way to provide on-the-spot education that probably will have more of an impact because it's information that's needed right away, and it's kind of context-driven. So based on some of the work we've done with Comfort Care Rounds, we've since worked with Canadian Hospice Palliative Care Association and identified, I think we have 8 different scenarios that we found have been common topics for discussion at Comfort Care Rounds. So we've developed some guides to help facilitators hold Comfort Care Rounds. The challenge is, like everything in long-term care, it's hard to get staff time to do this. So, it's hard to get staff pulled off the unit for an hour. Some of our sites have moved to huddles where there's these quick, 10-minute, you kind of huddle together at the nursing station to talk. So we've, wanted to develop these tools to help guide some of these conversations. So we have these tools. They should be, CHPCA should be launching them, I believe, by January. They're just hot off the press. The other piece that we've been working on, partly because of what we've been seeing in our data around the lack of training and the need for training and education for support staff and PSWs. We've worked with, some of you may know, Elizabeth Antefo, again, another BC, lots of things happening in BC. So Elizabeth's been helping us and really crafted these 8 modules. They're amazing. And we've been getting them put online as e-learning modules. And we're just ready to launch them, I think, in the next couple of weeks. We've had to do some tweaks. They're, open access, anybody can access them. We wanted something that was easy for PSWs and support staff to use, something that could be used during orientation, and they're short. Each module we've tried to keep under 12 minutes, so they're very short, really just the nuggets of what are important for support staff and care aides, personal support workers to know to implement a palliative approach. We've also have some tools for residents and families. Again, these are all based on our PAR approach and what we've been seeing in our research and needs that we need to address. So one of our very first challenges, Tamara Sussman, who's a social worker at McGill, and I have been working together fairly closely over the past 7 years. One of the first things we realized when we were trying to implement our SPA program was, the need for to have earlier conversations. And when we talked to staff, they would tell us, "Yeah, we really need, families need to be thinking about this a lot earlier." And then when we asked them, "Would you feel comfortable talking to them about some of these issues?" They're like, not really. But they feel it's important. They want someone to support families, but most of what we were hearing, they didn't feel prepared themselves to have those conversations. So a quick fix, we're in the middle of launching our research study. We developed these pamphlets. And the first one, we made them condition specific because we wanted families to know what to expect within different conditions, because they're all slightly different, as you know. And we looked at 5 common conditions. So dementia was definitely one of the more common conditions. And we had other ones looking at heart failure, advanced lung disease, kidney disease, and then just frailty, because most residents don't just have one condition, they have 2 or 3. So frailty kind of caught everything. And our 2 most popular ones are frailty and dementia that seem to be used the most. And this is one of our sites. You know, we've had homes just put them up for families and residents to access when they're ready, when they want that information, and staff as well have used them. So some fairly positive findings from these pamphlets. We've had a lot of uptake from them across the country, and even in BC. I think we have some BC specific ones as well. We have them specific to each province because the resources are slightly different for each province, and the language is a bit different. Tamara Sussman, who I've mentioned, led to 2 of the evaluation papers for the pamphlets here. And generally, what we're hearing from families is that after reading a pamphlet, it did encourage them to reflect a bit more. It helped to clarify what questions they should be asking healthcare providers, and they felt a little more comfortable about talking about end of life. But interestingly enough, it didn't actually help produce action. So it was more reflective, contemplative, but didn't actually get them to start having these conversations with their family member or resident in long-term care. So we moved towards another tool for another study. It's called Your Conversation Starter Kit. And I know in BC you have some excellent tools as well that are similar. This was one that we found and we liked because it did have a focus on dementia and Alzheimer's disease, and had the purple booklet for families, and then the orange booklet was for residents to use. But essentially, you know, same kinds of things we're seeing in a lot of advanced care planning tools, getting ready, you know, getting set, you know, kind of taking stock of what's around you and who you should be having these conversations with, and then having the conversations. So things, you know, around what's important to them, and having it in a booklet seems to make it a little bit more comfortable and guide families and residents about the types of conversations they should be having, and then keeping it going. So very, very simple booklet, but we found some pretty positive findings from using it. So we have a bunch of papers actually on the evaluation of the booklet. The one Tamara has published a few, and this is the one that I led, looking at residents' perspectives. So we had 44 residents from 3 long-term care homes here in Ontario, and so we did some baseline assessments. We looked at engagement and advanced care planning was one of the tools, and introduced the toolkit, the booklet, and left it with the resident or the families, and the resident either went through it by themselves, which isn't really what we wanted, worked with the research staff, again, not really what we wanted, or ideally, you know, sat down with their family and talked through the booklet together. So what we did find some significant improvements in that they reported that they were asking more questions to healthcare providers. So this is residents, which is great. We don't often get a chance to engage residents in long-term care. These were ones that were fairly well cognitively intact, and you know, had moved into the long-term care home, and we caught them kind of at the early end. So we did find that they were more comfortable asking questions to healthcare providers, which is a good thing. When we asked families, we used a self-efficacy and decision-making tool, and similar, we had them completed at baseline, and then after they completed the booklet with the residents. And at baseline, they actually reported pretty high scores in terms of how confident or certain they were that they would be able to make decisions on behalf of the resident. But after working through the workbook with the resident, they were less confident. So of course, it's like, oh no, this isn't what we had hoped we would find in our study. But then when we started thinking about it a bit more, we realized that the conversation starter kit actually really educated them about what kinds of things they'll need to be making decisions about at end of life, and things that they, the types of conversations that they need to have with the resident while they can. So we think it was actually a good thing because it raised awareness around things that they need to get doing right now while the resident is still able to have those conversations. So I mentioned a palliative care conference. So the pamphlets, the conversation starter kit tool, we consider them more what we call front end tools and resources. So advanced care planning, they would fall under that piece when the resident isn't nearing end of life and able to engage with some of these conversations. But then, there's always resident decline at some point, and then they approach end of life. So this is where a palliative care conference or a goals of care conference is really important. So we bring, I've already spoken a bit about this, and it's an opportunity for families to come with the healthcare team. It's triggered by a palliative performance scale. So we often use 40%. For those of you who have seen the palliative performance scale, it goes from 0 to 100. 30, we've noticed, is a bit too late. Some of them we're not even catching in time. We can't get them to a family or palliative care conference in time. So we generally bump it back to 40%, so we can have time to have a palliative care conference. Fairly good results. Again, we had a pilot evaluation, which was largely based on the palliative care conference and some of the decisions that had to be made in the conversations that happened during those family care conferences. And we found from our cohort, we only had 38 residents, but from our cohort, 82% of them were able to have a palliative care conference before they died. So we were happy about that. It would have been nice to have 100%, but the ones who passed away were the ones generally with the scores less than 30%. And we did see a 55% reduction in ER visits in the last year of life. So residents and families who had a palliative care conference and were part of our SPA program generally stayed in the long-term care home during end of life and died in the long-term care home. So that was one of our goals because we often see not the best experiences when a resident gets transferred to the hospital. It takes a lot out of them, hard for the families. They're around new people, which is particularly challenging and off-putting at end of life when people want to be around familiar people that know them well. So COVID certainly has, created havoc in a lot of different ways. Certainly, we've seen how the long-term care sector has been hit very hard, but also exposed some of the challenges that we're faced with. So I think we're all feeling like we're coming out of our hole and starting to kind of take stock with where we're at right now. I know 2 of my studies have been put on hold for 2 years, so we're now trying to figure out what our SPA program will look like because of COVID, and trying to move forward and look at next steps. So one of the things that we did do during COVID, we partnered with Canadian Hospice Palliative Care Association, who were funded through Health Canada, to adapt a toolkit that we had been working on before COVID to help support implementing advanced care planning and long-term care. So we quickly did a bit of a scan, looked at different tools that were out there for COVID in particular, although a lot of them could be used after COVID as well. And also, looking at some of the experiences that long-term care homes had during COVID. So we managed to get most provinces involved, and we had 38 people interviewed, different stakeholders from across the country. And we kind of categorized the resources that people were using, and these are the categories that we use. So a lot of advanced care planning tools, goals of care, not so much for grief and bereavement. That's something we often fall short on, and certainly during COVID, not as much out there to support families and residents. In terms of the audience for some of these tools, we found most of them were for healthcare providers, staff in long-term care, and families, and some for residents. And we organized where we managed to find the tools, and you can see again, BC is a shining star and had the most tools that we could find related to advanced care planning and long-term care. Ontario had some as well, but by far BC, largely because of the work that's happening there within the Serious Illness Conversation Guide, and some excellent stuff happening. The other piece that I think we all felt, and some of you who maybe clinicians yourselves, it was not an easy time for clinicians, and lots of moral distress. And I think we're seeing that now. I've been working with a couple of research teams who have done interviews with staff. Really some horrific experiences. But on the plus side, if there is a plus side, I think lots of work, or at least some work, is starting to happen to recognize that staff are grieving themselves in long-term care, and it's not an easy place to work. And then also seeing multiple deaths in long-term care, and with COVID, crazy numbers. So how can we support staff in their grieving and bereavement as well? One of the things we started working on before COVID, Jo Hockley, who some of you may know, she's on the far left here in the video. She's from the UK and has done really some excellent work implementing the gold standards framework in long-term care homes there. And one of the things that she developed was this reflective debriefing exercise. So similar to some of the activities we do within our comfort care rounds, she's labeled it reflective debriefing. So it's primarily around supporting staff reflect on previous resident deaths and helping them cope with some of those deaths that particularly didn't go well. So I saw this video. It was developed for another research study in Europe, PACE, Palliative Approach, Comprehensive Education, or something like that. I can't remember, but it was part of that study. And so I approached Jo and some of my other colleagues who were involved in that study, because I thought this video was magnificent, but it was an hour long. So how can we convert this to a nice teaching tool for staff? Because I think it's important. They need to take time themselves to reflect and time to grieve. So we worked together and edited the video down to about 12 minutes now. You can access it on the YouTube channel I have here on my slide. It's wonderful. It's wonderful. You'll cry. It is a sad one, but very much needed. And Jo is really excellent at doing these kinds of activities. So we're lucky to have her. She's just emailed me. She is retiring, she's telling me. So we're lucky to get this out before she retired. The other piece, I think that COVID, some of us have always felt this way, but COVID, I think, has really shown that, we need to focus more so on a psychosocial model of care as the traditional biomedical model of care. You know, people, this is their home. They are certainly sick and they have lots of, you know, medical issues, but we're not giving the attention to the psychosocial side that we need to for both the resident and families. So we really want to encourage and put more emphasis on the psychosocial model of care within a palliative approach. The other piece that you know, has always really intrigued me is, and I'm sure many of you have known as well, I think you're engaged in compassionate communities in BC as well, is how can we, you know, get everyone really more comfortable about death and dying, and how do we get everybody taking responsibility to supporting people who are dying or even, you know, not dying, I guess, but talking more about dying and preparing more for dying. And this really looks at a cross-sector perspective. So how can we get, you know, schools more involved in coming into long-term care homes, art museums, you know, how can we broaden the way we look at a palliative approach and long-term care so we can break down the walls of long-term care homes and make them more part of the community. Lots of things we could be doing, and I think this compassionate community initiative really opens the door for a lot of those things. Final thoughts. I've lost track of my time. I have no idea how close I am. I hope I'm not going over. But final thoughts, you know, I think it's very clear we need to build capacity in long-term care homes many different ways in order to implement a palliative approach to care. It needs to have a stronger focus on family-centered care within a psychosocial model, and ideally, you know, have the long-term care homes more a part of the community, not isolated where people don't know about them or hear about what's going on inside the walls. You know, we need them to be just as much a part of the healthcare system as hospitals. Next steps, this is my marketing piece now. We've developed or organized a community of practice across Canada, so it's really anyone interested in implementing a palliative approach in long-term care. We have people from all walks of life, even some family members part of this. This was an advertisement for our first session. It really is a neat group. There's a lot of dialogue. We have presentations once in a while, and we're really using this opportunity to learn about what's going on across the country and networking and trying to support one another for those of us interested in this area. So I would welcome many of you to join. Here's the link to join. Again, Canadian Hospice Palliative Care Association is organizing the community of practice, and it's something we're really excited about. We started with 7 people, and we're over 200 now within less than 6 months, I think. So we'd love to have some more people from BC on our community of practice. The other piece, my team and I, we've just, with Mary Lou Kelly, we've pulled her out of retirement. We were approached from Health Canada about a year ago to develop and help support long-term care homes implement a palliative program. So we developed what we're calling the SPA-LTC Alliance. It's very open again. We're all working together to share resources, and it is definitely a national initiative. So if any of you are interested in joining, we're hoping to engage BC in some of our work. We've already tapped into a few people, but would love to get more people involved. And we plan to have different hubs across the country. And there's, you know, this funding available to help support implementation as well. Part of that is kind of leveraging the work that many of you probably in BC have been involved in around the Serious Illness Conversation Guide. There's some, you know, it's an excellent tool, and how can we leverage this tool to use in long-term care homes? You know, we are a bit unique, us in long-term care. but we're looking at developing some tools to implement it and hopefully get some work done within electronic charting systems as well in long-term care to help probe some of these conversations. And this is my last slide. I'll leave you with our website in case you want to take a look. It is going to be going through some major revisions, though, with our new Health Canada grant. We hope to build a repository of tools so that it's easy to access for people. What we're finding, there's lots of tools out there, and I don't think we need many more tools, to be honest. But how can we package them and support staff with implementing the tools? I think that's what's very much needed. Well, thank you very much for your time. I would love to see and hear some questions. And again, I hope I haven't gone over my time. I tried to get my stopwatch on, but it's gone black, so.
No problem. Thank you so much. That was a very detailed and thorough overview of so many tools and resources. But I think what impressed me the most was not only the number of helpful resources, but the evaluation of those resources and use of them as well. And your efforts to promote their uptake, I think, is a real model for us all. It's not just about developing resources, but also evaluating them. Do they work like we intended them to? And I think your research really speaks to that and provides some very helpful information for going forward. So I'm really looking forward to this website to bring all these beautiful resources together. And thank you so much for highlighting the great work in BC. It's also great to know that our colleagues here in BC have contributed to that work in really meaningful ways and been part of this whole effort, which has been so important, both in the past, but currently now, even more so. So I see there's a couple of comments and questions, and I encourage people to add them to the chat box. There's one, I'll start off and then I'll turn it over to you, Clara. The first one's from Patty. What platform or organization will the e-learning modules be made available through?
So yeah, so thank you for that. I hope you don't want to know the actual program because I'm not an IT person, but we will be putting them on our SPA website. So we're using them for a research study right now, but we will be opening them up for other people to use as well. So hopefully by the end of next week, they'll be on our website that you can access quite easily. If you want to know kind of the education IT program, if you name some names, I might be able to tell you what program that is, but hopefully it's just about where and website, and I can answer that piece.
That's great, thank you. Clara.
Thanks, Sharon. There's another question, and that's actually in line with me, and it was related to the research about having a palliative care conference and the reduction by 55% in ER visits, and then 72% decrease in resident death in the hospital. That is so significant. Can you tell us a little bit more about what specifically was contributing to those big changes?
Yeah, really good question, and an important one, I think. So what we noticed with these family care conferences.
Oh, I've lost you there, Sharon. Oh. Yeah, you're on mute now.
Yeah, maybe it's just because you have the mute button on, I'm hoping.
Yeah.
Ah,
So there will be a bit of a delay.
Don't
I'm
worry.
now using my video audio. And I cut people off, so I apologize. But so I think what we were finding in the palliative care conferences is it gave families a chance to have their questions answered,
okay.
and some of their concerns about going, to the hospital or staying in the long-term care home. So it could have been, even around pain management, knowing that those resident needs can be handled very well in the long-term care home, and having plans in place. So it made families feel a little or quite a bit more comfortable. So there's a lot of discussion, a lot of planning, and I think families felt more confident with keeping them in the long-term care home as opposed to sending them to a hospital. And we would often, we had field notes from when families first came and sat down at the family care conference. And one family member, was clearly upset and stressed and angry. And by the end of the family care conference, after having that opportunity to talk about some of their concerns and get their questions answered, all of a sudden she was relaxed and said, I feel so much better. I've got all my questions answered, and I feel like we're all on the same page. So even just seeing that transition happen, and it just amazes me that this isn't just standard practice. Like it's just having families involved in this kind of discussion, why it has to be a big deal, really, because it's so important. And certainly, our data is showing, and families are much happier with not having to send residents to the hospital, because I don't think they want to do that either, but they're worried about some of the consequences. So just being able to talk about that and prepare for that, I think, helps them feel much better.
Yeah, and what I'm hearing from you is that there's this increased confidence of family caregivers in that decision making, and that helps
Exactly.
with is what we know is really important is the chosen place of death, whether it's at home in their long-term care home or in hospital or in hospice. That's wonderful.
Mm.
I'm
Sharon,
curious.
does it matter if these family care conferences are held in person, or could they be held these days by Zoom? Does it make a difference?
Yeah, that's another great question, and I know some people actually looking at that in particular. So it's I guess we don't know quite yet. We haven't kind of done a comparison, but our colleagues in Saskatchewan, that was the only way they could have these palliative care conferences even before COVID, because it's you're looking at rural homes and family members living at a distance. So they seem to work just as well. But I would think, having that in-person meeting ideally would be good. And, having kind of building on the relationship that they currently have with staff, having those staff in the family care conferences as well. And sometimes, that can be a healthcare aide or a personal support worker. But having people that they're comfortable with and have those relationships. But yeah, I think the virtual, I have colleagues that have had to do that over the last 2 years, and they've made it work. And the interesting thing as well that we've been seeing, and it came up in our environmental scan, is people are saying, oh, I'm much more comfortable now using the serious illness conversation guide, because they were forced to do it during COVID. They had to have these conversations. So I think it's another, silver lining in all of this is people were forced to have these conversations. They couldn't avoid it. And now they're feeling, much more prepared to have them in the future. So that's a good thing, I think. We
That's
can't,
great.
we couldn't avoid it during COVID.
And people got lots of practice, unfortunately.
Exactly. Yeah, yeah.
Well, our time is up. I know that we could talk about this for a long time because there is so much that you have shared with us today. But we look forward to hearing further updates from you, and of course, seeing the website as it gets revamped and populated with all these great resources so that they're accessible to everyone. So on behalf of the North Okanagan Hospice Society and the Institute here at UBC and everyone who attended, thank you so much for joining us today and sharing this research. And we look forward to hearing more about it in the future. So thanks everyone for joining.
Yeah, thank you.
Bye.
Wonderful.
Thanks. Bye.